Presentation. Are we live?
Yes, already.
Yeah. So
thank you for the invitation to talk today about the surgical challenges of diverticular disease. There's been a sea change in our understanding of diverticular disease over the past decade, and a number of things have changed, not least things like the nomenclature. And the recent European Society of Coloproctology guidelines published in colorectal disease have highlighted some of the things that have changed, including the concept of symptomatic, uncomplicated diverticular disease. Things have moved on a long way since the initial descriptions of diverticular disease and the classification that Hinchey described back in the 1970s. And we now find ourselves in a situation where we have widespread use of CT scanners to help us in our diagnosis of patients with acute diverticulitis. There have been several attempts to classify the CT appearances, but none of them have achieved widespread general acceptance. What we can say is that when intraoperative Hinchey classification has been correlated to the CT reports, that we find that the accuracy of diagnosis is not as good as we would hope. And we can see that particularly for Hinchey grade 3, over which there is much debate about the management, the accuracy is only around 70%. And the inter and intra-observer variability of CT classifications are as yet unknown. Having said that, many of the studies over the past decade have tried to differentiate between uncomplicated and complicated diverticulitis. And to that end, the Wasbury modification of the Hinchey classification has been widely used to that end. One of the key questions that have been asked over the past decade was whether patients with uncomplicated diverticulitis needed antibiotics or not, or whether they could be managed just with observation. There were 2 randomized controlled trials conducted to try and answer this question, and this systematic review published in BJS earlier this year is an individual patient data meta-analysis which combines the data from both trials together. You can see that the groups are very well matched, and when looking at the outcomes between them, there are no real significant differences between the 2 groups, except for the length of hospital stay, which was longer in the patients who were having intravenous antibiotics. Consequently, the ESCP guidelines have stated that in patients with acute uncomplicated diverticulitis, they do not require antibiotics routinely, and it should really only be reserved for those who are immunocompromised or with sepsis. So what about those who've got complicated diverticulitis? Well, a number of studies have tried to answer that question, particularly those which look at patients with Hinchey 1B and Hinchey class 2 pericolic abscesses. And the systematic review from Jacob Rosenberg's team in Copenhagen has collated the evidence from non-randomized studies together. It's worth noting that those patients who were treated just with antibiotics tended to have smaller abscess sizes than those who were treated with percutaneous drainage. And also, those just on antibiotics were more likely to have Hinchey 1B disease. Nevertheless, in all groups, treatment seemed to fail approximately 20% of the time. And of those who were managed conservatively initially with just antibiotic treatment or indeed with percutaneous guided drainage, approximately 25% got recurrent. And so overall, your long-term success with this non-operative management strategy is only about 60%. And for those who do undergo surgery, the mortality rate is high at 12%. So about these abscesses, what's the best way to treat them? Well, whether to have a drain or not can be influenced by the size of the abscess. We know that patients who are on antibiotics alone, if the abscess is greater than 3 centimeters in size, are much more likely to have treatment failure in this large multi-center study of patients undergoing non-surgical management. Patients whose abscesses are greater than 5 centimeters in size are more likely to have their percutaneous drain fail to control the infection and the required surgery. There remains some uncertainty regarding the best treatment for pericolic abscesses in patients with acute diverticulitis. And so European Society of Colour Proctology have issued a statement which says that although the role of percutaneous drainage is not completely clear, it may be considered in those with abscesses greater than 3 centimeters. It's because of this uncertainty that there are still ongoing research studies to try and elucidate exactly what is the best way to manage such patients. And this large international multi-center observational study was launched this week. Damascus has got centres recruiting in North America, Europe, the United Kingdom, Australasia, indeed all around the globe. And if anyone in India would like to help participate, please get in touch with the email address on the screen. So what group of patients need surgery? Well, if we've managed Hinchey 1A with just observation, 1B and 2 with antibiotics plus or minus percutaneous guided drainage, how do we manage Hinchey 3 patients? Well, certainly some studies have opined that if they are stable and immunocompetent, then they too could be managed just with antibiotics, and over half could avoid an operation. And certainly the ESCP guidelines seem to support observing those immunocompetent and hemodynamically stable patients who have got perforation and signs of extraluminal air. Surgery should be considered for those who are hemodynamically unstable or frankly septic. But what to do in some of those patients? Well, in those who've got fecal peritonitis, it's a surprisingly evidence-free zone in terms of randomized controlled trials, with no clear evidence to guide us what to do. And so to that end, the ESCP guidance has suggested that the surgical approach should be related to the experience of the operating surgeon. What about those patients with purulent peritonitis? Does laparoscopic lavage have a role? Well, this concept has been around since the dawn of laparoscopy in the early 1990s. And essentially, there have been 3 randomized controlled trials which have tried to answer the question as to whether laparoscopic lavage is as good as primary resection when one considers whether there are further interventions. And we can see from the forest plot on the screen that patients who underwent resection were much less likely to have further interventions compared to those who had laparoscopic lavage. The groups were well matched in all the studies, and if you look at secondary outcomes such as postoperative intensive care unit admissions, 30-day mortality and so on, there doesn't appear to be a great deal of difference between the groups. What happens in a situation outside of a randomized controlled trial when you put the technique into the hands of a wider group of surgeons with a wider group of patients? Well, this prospective multi-center study examined just that question and found that long-term success occurred in approximately 2/3 of patients, and that the indicators for failure of such a treatment strategy were due to the identification of free colonic perforation. Those patients were unlikely to do well just with lavage. And so the ESCP statement that laparoscopic lavage is feasible in selected patients has been made, but it's a relatively cautious statement. And what has never been examined is whether the patients who have got better with laparoscopic lavage for the same group of Hinchy 3 patients.
2 minutes to go.
French data was suggesting would have got better just with IV antibiotics. So those who do need surgery, what's the best way forward? Is it to do HARTMAN'S procedure, which was the standard of care from the 1950s onwards, and then consider reversal at a later date? Or do we do a resection, wash out of the colon on table, primary anastomosis, and a defunctioning ileoileostomy? There have been 4 randomized controlled trials which have examined this question, and this recent meta-analysis provides a synopsis. What we can see is that the groups tend to be well matched, and when you look at either morbidity or mortality, there seems to be no difference in those patients who had a primary anastomosis and those who had a non-restorative resection. And when you look at what happens when you restore gastrointestinal continuity, we can see that it strongly favours those who had primary anastomosis, because closing a loop ileostomy is a lot less challenging than reversing HARTMAN'S, particularly in terms of morbidity. And we know this because repeated series describing reversal of HARTMAN'S have all demonstrated how difficult it can be. With low rates of patients having it completely achieved laparoscopically, we still find that more than 1 in 5 require temporary loop ileostomies, and over half have a significant morbidity. Yet, despite the evidence and the approval of ESCP about using primary anastomosis with or without diverticular loop ileostomy, we can see that it really hasn't penetrated into the colorectal community, with low rates of uptake, as illustrated by this data from North America. What happens after the patients have finished their acute episode? What do they need in terms of follow-up? Is anything required? Well, it depends upon whether the initial index admission was for uncomplicated or complicated acute
1 minute to go.
Rates of colorectal cancer in the uncomplicated group are very low, whereas those with complicated acute diverticulitis, the rate of colorectal cancer is somewhat higher. And so for that group, endoscopic follow-up is still recommended. So in summary, diverticular disease remains one of the most complex conditions we treat. The decision-making is complex and it can have a profound influence on the morbidity and mortality of our patients. It's technically challenging surgery, whether it is done lap or open, and the guidelines that we have are a helpful synopsis of the evidence for best practice. Thank you.
So thank you, Dr. Smart and Professor Smart, and for that wonderful presentation. There was one question. I think we have time only for one, and the questions are asked about. He has the situation which a delegate has mentioned in the question answer box, saying that he has a perforation at the angle. I am not sure what he means by the angle. He has perforation and obstruction at the angle. So what do you think? What would be your solution to it, Professor Smart?
Depends exactly what they mean by the angle, but usually if it's the angle of the descending and sigmoid, or if it's the angle of the rectum and sigmoid with the joint, normally if they've got perforation there, then I would go for resection personally. Depends upon the stability of the patient hemodynamically, and often if they are stable enough, I would like to do a primary resection and anastomosis. I have to say I'm a big fan of on-table colonic washouts, primary anastomosis and defunctioning loop ileostomy, because I find it far easier to close a loop ileostomy than putting HARTMAN'S resections back together again, which inevitably is a thankless task with several hours of adhesiolysis beforehand, which is not fun if you're doing it either open or laparoscopic, it has to be said. So my preference is to resect and anastomose where at all possible.
Thank you, Professor Smart. and that is all time we have for. I'm sure there'll be a lot of questions in the question box. Can we move on to the next presentation, please? For joining in this prestigious INDO-UK Surgicon, and thank you organizers for giving me this opportunity. I'm here to talk about quality of life issues post-rectal cancer surgery. And why so? Simple, because we are the land of the Kama Sutra. Well, jokes apart, my friend Saklani actually did this audit in Tata Memorial Hospital, and nearly 75% of the patients are between the age group of 20 to 60 years. This is a young population, a productive age group, and hence definitely quality of life has a big role to play post-surgery. Is sexual function important for patients? We sometimes do not think that it is important, but if you really go and ask them, it definitely turns out to be an important issue in their life. This was a Brazilian study which found out that nearly 80% patients consider it either important or the most important factor of their life. What about permanent stoma impacting quality of life? Permanent stoma obviously has a negative impact. There are psychological, marital, and social lives are impaired. There are limitations in daily activity. A simple thing like praying to God becomes a big issue because there are various social taboos regarding the stoma. It is financially draining. We have no idea what the stoma bag costs, and it is really financially draining for them. And hence, every serious colorectal unit should have a stoma nurse with them. Counseling becomes extremely important in order to help patients who have to go ahead with permanent stoma, irrespective of whatever we do, and where stoma can be avoided, it should be avoided. Third most important thing for quality of life is the low anterior resection syndrome, or LARS. Now, for surgeons, what is LARS? Very simple. Disordered bowel function leading to a detriment in quality of life. Now, look at it from a patient's point of view, and it is completely different. My surgeon explained the possibility of LARS as a quality of life issue, and I had no idea how difficult it would be. And so for the patients, LARS is a very, very big deal. Now, how is LARS? LARS varies from 40 to 80% in patients, depending on various sources in the literature. It is measured by scores like Wexner and the LARS score. Essentially, there is incontinence, bowel frequency, and an influence on overall quality of life. There are some factors which independently affect LARS, whichever surgery you do. Age more than 70 years, tumor distance from the external anal verge, neoadjuvant treatment, especially radiation, has known to be negatively impacting LARS. Interval time of the closing the stoma. If you wait for too long, sometimes the incidence of LARS is higher, and sometimes comorbidities like diabetes also negatively impact. I would urge serious students of colorectal surgery to read this article from Professor Narimantas from Lithuania. We know he has a huge body of work. Superb article recently appeared in Scientific Reports in February. How do you manage LARS? Well, it is a management basically consisting of Kegel's exercises, judicious use of medications like Isabgol and Imodium, stool training, biofeedback, and most importantly, counseling. Managing stress, because stress is caused by LARS and LARS is caused by stress. So that vicious cycle needs to be broken. There are dietary changes that are important. Eat small, frequent meals, plenty of fluids, foods that help to firm up stools like white rice, bread, potato, etc. And avoiding foods like carbonated beverages, beer, milk, nuts, and certain vegetables like cabbage. All this goes a long way in order to manage LARS. Now, what is the important factor as surgeons we can do to improve quality of life? And for that, to paraphrase Bill Clinton's famous slogan, it is the nerves. The autonomic nervous system is what is the most important thing. And what is this autonomic nervous system? Basically, it's a bunch of nerves which have two origins. One, the sympathetic supply coming from the T10 to L2, where it gives off a branch to the inferior hypogastric nerve, which is a mixed nerve, which also takes branches from the plexus from S2 to S4, giving parasympathetic output, and ultimately supplies all the genitourinary structures in the pelvis. So that is what forms the autonomic nervous system. And if you see it from a surgical anatomy perspective, it is the superior hypogastric plexus forms somewhere near the origin of the inferior mesenteric artery, and then along the pelvic rim are the hypogastric nerves, and then
at the seminal vesicles or at the vaginal vault is the inferior hypogastric plexus. So that is where the surgical anatomy is. Now, where are the nerves that can get injured? Incidentally, there is a lot of articles in urology which actually talk about sexual dysfunction and bladder dysfunction post-rectal cancer surgery. So a lot of urologists keeping a watch on us. So we have to really pull up our sleeves and see to it that we do a better job at that. Because these are the areas where nerves could get injured. For example, during the dissection of the IMA, and what does it cause? It can cause a retrograde ejaculation and stress urinary incontinence. If it gets injured at lateral dissection, it can lead to incontinence and problems with ejaculation and erection. And if it gets injured at the inferior hypogastric plexus, then it can lead to impotence and erectile dysfunction in males. And in females, it can lead to dyspareunia and reduced genital lubrication. So a lot of impact at each level, the impact is different. Now, how do we save these nerves? Now, for example, when you're talking about the superior hypogastric plexus, a lot of times we talk a lot about high ligation, low ligation, but we never talk about what impact it has on the nerves. So one thing we could do is when we enter into that holy plane of heel, leave a little bit of that thin areolar tissue over the nerves. This is the angel hair that you can see of the TME plane, and you can see the nerve here, which is covered by thin areolar tissue. Second, as you go on to the artery, remember that even if we are doing high ligation, if you take out all the fibrofatty lymphatic tissue and leave about 1 to 2 centimeters from the origin, the superior hypogastric plexus is going to be thankful to you. Now, next is how do you save the hypogastric nerves and the branch to the hypogastric nerve? Now, here, as we go into the TME plane, we should remember that there is a nice plane that does exist between the mesorectal envelope and the nerve, and it needs to be teased out. Gentle, blunt, and sharp dissection. As you can see here, the nerve is being dissected. In our zeal to identify the ureter, a lot of times we disregard the nerve, and the man ends up getting erectile or ejaculation problems. So this is something that we need to keep in mind. The third is saving the pelvic plexus. Now, this was a very low anterior resection, and this is typically the area where you can actually injure the nerves. Now, we have dissected, if you will see here, both the nerve and the ureter has been dissected. We have now retracted the seminal vesicles here, and now we follow the nerve and keep a small nice fascia over the seminal vesicles, which essentially protects the plexus. And that is one way that we can help keeping the man's potency. Now, does approach make a difference? There are literature reports which say that the incidence of urinary and sexual dysfunction after open TME is significantly high. So laparoscopic approach does have an advantage here. And I think it is simply because of the kind of vision that you get in laparoscopy, magnified, the nerves really come out well, much better than in open surgery, and more so in robotic surgery, as my chairperson, Dr. Venki, would agree that in robotic surgery, your nerves really look very nice, and it is much easier to preserve the nerves. And that has been the findings in some literature reports as well. Does type of procedure matter? I'm sure it does. There are no RCTs to prove that, but lateral pelvic node dissection or an extra levator AP, definitely the incidence of nerve injury is definitely more and can lead to decreased quality of life. We did our own study for quality of life in patients. We used the EORTC, QLQC 30 and CRC 29 questionnaires for the same. And out of an entire pool of 500 patients, only 84 were willing to talk. This was retrospective data, telephonic interviews which were taken. We had sexual dysfunction in 20% compared to the literature average of 40 to 50%, urinary dysfunction in 10%, diarrhea in 20%, and pain in 23%. So nearly 1 in 5 patients does end up with some kind of dysfunction after low anterior resection surgery. As far as the age is concerned, with increasing age, there was a little increase in the symptoms, not statistically significant, but definitely more. Rest of the findings, as far as international literature, Lizentis was the largest trial we encountered, was similar. if you see the symptoms as well, except for constipation, which was higher in European patients, the rest of the symptoms were the same. The rest of the problems were the same as far as rectal cancer surgery is concerned. Now, if you go by T stage, that is one thing we compared. Most of the symptoms were more as far as T stage is concerned. Obviously, more extensive dissection leading to more incidence of post-surgery symptoms. End staging also showed a similar correlation, not statistically significant, but everything is more in N+ patients, including financial difficulties were more. Obviously, N+ patients are going to require more intense chemotherapy. They could have more recurrences. There are more problems, definitely. Then that is why the quality of life is poorer. So to conclude, quality of life parameters are comparable to Western literature, and there is deterioration in parameters with advancing age and stage, though it is not statistically significant. So what should we do as surgeons? One, pre-op assessment is extremely important. We need to know that this patient will have more incidence of something like LARS. We have seen the prognostic factors that are there. We should have a structured training and exposure to pelvic neuroanatomy. Nowadays, we talk a lot to our residents about preserving the ureters and vascular control and how there are complications. Nobody talks about the nerves because that is something that happens when the patient goes home. Exposure is extremely important. As I said, we are dealing with a young population, and hence preserving the nerves and quality of life is very important. Obvious advantage of minimal access surgery. We must increase training opportunities. You are all seniors here, and an organization like IAGES should take this to where laparoscopy is not there and improve the penetration of laparoscopic surgery, which currently in India is very low. Thank you very much for giving me this opportunity. Any questions? I would love.
Thank you. Thank you all. There are no questions. We will move on to our next presentation.
Thanks of all the organizing committee.
Yeah. So the next
for his invitation to participate to the third international and midterm virtual conference to speak on Transanal TME for rectal cancer and to discuss if it is a procedure that will stay in the future. It is a procedure proposed as a method to improve surgery of mid and low rectal cancer. It's a hybrid TME using a minimally invasive abdominal approach by laparoscopy or robotic and transanal approach. It has the potential to be safer for the distal resection margin as proposed in the 80s by Gerald Marks for distal tumor. In type 1 lesion, the tumor located more above 2 centimeters from the anorectal junction, it is the best indication because we can do approach with a platform in place at the beginning of the procedure, avoiding a local contamination risk. But for the tumor lower than 2 centimeters, the operative platform cannot be introduced immediately. We have to dissect distal first. We have to differentiate different types, but all with a tumor reaching 2 centimeters, the distance of the anorectal junction or less, we have to do either a sleeve mucosectomy or partial intersphincteric resection or total intersphincteric resection, depending on type 1B, 2, or 3. When we have this type of tumor, we have to take care with the risk of local contamination by cancer cells, and we will see that this is a risk of local recurrence rate. And we can say if the laparoscopic assisted transanal TME is considered as a common technique. Actually, we have problem. There is no consensus to say what we have to do first, beginning by transanal way or beginning by transabdominal to do a panoramic exploration and evaluate the possibility to do the surgical procedure. And when we have to stop the abdominal step too, for Dapri, Giovanni, he proposed to stop 1 centimeter down the promontory. But I will say, why not continuing if it's easy to do all the procedure by transabdominal? A procedure mixing both, doing transanal and transabdominal, we do since a long time. This is the case with a single port in or the right iliac fossa for doing the dissection of the vessels to do the mobilization of the sigmoid and splenic flexure, and doing transanal way the perirectal dissection. And we can have a procedure with one scar for the diverting and protective stoma. So there is a big difference with the pure transanal I promote 10 years ago and proposed to do. It is a pure notes rectal TME technique without laparoscopic assistance. We do all the procedure by transanal way. The best indications are for tumor located more than 2 centimeters from the anorectal junction, the type 1A lesion, with a long sigmoid loop, because we will have sufficient space available to allow an endoscopic purse string placement with the adequacy of the distal margin about 1 centimeter distal to the tumor. We begin with a team between the leg, and we will close the distal rectum, performing a purse string, a full thickness purse string with monofilament 2-0 sutures, 1 centimeter distal to the distal margin of the tumor. Then we do posterior incision, and we will dissect the presacral space back to the propria fascia of the rectum. There we will do lateral dissection between the sidewall fascia and the perirectal fascia. We open the space and we will divide all the structure crossing the space coming from lateral to going to the rectum, and we dissect medial to the sidewall fascia that is protected, the distal plexus. Pelvic plexus is protected by the sidewall fascia, and we will only divide the neurovegetative branches crossing this space to go to the rectum. On right, on left, and this is how we can do a safe protection of the plexus. Then we continue anterior. We open the Douglas pouch, and it's easy in female patient, but in male we have to dissect behind the prostate and the urethra with high danger, particularly after radiation. That is for me not the best indication for operating during the transanal approach. And we will dissect the plexus branch running posteriorly to the root of the mesosigmoid. We will dissect from down to up. And we continue the dissection anterior to the aorta, and down to up we will see the iliac vessels then we will see the anterior aspect of the aorta, and we will reach the root of the mesosigmoid and the origin of the IME. And in this case, as you see, we see the left colic artery. We have reached pushing the long TO platform. The origin of the IME, we see the left colic artery, the sigmoid trunk, and the superior rectal artery, and we will do a division, in this case, distal to the left colic. Then we do the extraction of the specimen, and we do transanal, and we verified the quality of the specimen to be sure that we did a good oncologic resection. Anastomosis will be performed after, doing end-to-hand mechanical anastomosis, side-to-hand, with hemorrhoid stapler, long shaft, or manually doing side-to-hand or end-to-hand anastomosis. Results. The results, there is today no randomized evidence for the benefit doing a transanal TME. We have equivalent oncologic results. We have similar anastomotic leak and positive resection margin rates. But we have a long learning curve for doing this, and it is published in the literature as a long surgical procedure with worst outcome seen in the first 50 cases performed. It is why the Norwegian colorectal cancer group have found high recurrence rate after transanal TME, with a possibility related to the rectal transection airflow during the dissection. And they decide in December 2018 to stop performing this type of procedure, waiting, following the Norwegian Health Authority declaring a national moratorium for transanal TME, and waiting until the national audit will be complete. They evocate the problem of the learning curve for these procedures. That's why some team has Samatala structured training program for this type of procedures. And they trained 81 surgeons during 1 year and evaluate morbidity and technical problem after this course completion. And the problem they found significant procedure complication reported by the respondent, and it was particularly the urethral injury, whereby 25% respond this. It is why he concludes that it was useful for the majority of the surgeon, but due to the complexity of the procedure, it's not sufficient to train surgeons with this approach. Transanal TME technique still have many problems: high technical difficulty, high dependency of device platform, limited indication. Therefore, it will take a long time for this technique to be widely applied in clinical practice. But we can say, yes, this will be used for selected cases, but after a long training of the team. Thank you for your attention, and take care of you.
Thank you, Professor. Thank you for giving such a nice talk. You're a legend in laparoscopy, and maybe now transanal procedures also. Just one question: what is your comment upon the Norwegian moratorium? Do you think it is justified? Do you think it will change things, or do you think it will go away?
Yes, I think it is justified. Why? Because
I was traveling around the world. Actually, it's more limited. And what I have seen is not really what I want to be the patient. Because you see, people without training are doing surgery, but I'm not sure it is a standardized procedure. And we know that the results in surgery, in medical care, are due to a good procedure, well performed. And people are saying they do TATME, but they mix. It is why I have tried to show they mix up to down and down to up. But we do that since always. When it's difficult, we do distal dissection to have low, more preservation of the sphincter. And it is a recommendation of Gerald Marx, and after his son, John Marx. And Gerald Marx did that open in the 80s, previous century. So this is, we have to know how to do transanal dissection. We have to know how to do up to down dissection. But remember, we have never seen so many complications since we do transanal TME as we see actually in the world. Never we have seen so many urethral complications, for example. And we don't know all the case.
Absolutely true, sir. I think good mentoring, good practice, and a good knowledge of anatomy is extremely important for this procedure, more so than any other procedure. That's what I feel. Thank you very much, Professor Leroy. So kind of you to join us and give your valuable time.
Thanks for inviting.
Take care, sir. And we move on to our last presentation of this session from Dr. Ashwin D'Souza, who's a professor at Tata Memorial Hospital. Ashwin, over to you.
Thank you for this opportunity to present on pushing the boundaries in advanced rectal cancer. We have gone beyond the standard TME approach to push boundaries towards organ preservation, improving local and systemic control, increasing sphincter preservation, adopting minimally invasive resections, performing lateral pelvic lymph node dissection, and finally adopting extended and beyond TME for locally advanced and recurrent rectal cancers. This last boundary is going to be the subject of my talk today. Let me begin by defining extended TME by an en-bloc partial resection of the adjacent involved organs along with the TME specimen in order to achieve an R0 dissection. If one were to resect the entire organ, one would adopt a beyond TME approach, resecting according to defined templates for pelvic exenteration. Also included in this group is the extelevator APR. What is the need for an extended or beyond TME approach? The first indication is one for T4B cancers, which can occur in 5 to 10% of rectal cancers at presentation. In such situations, one would have to extend the surgical template beyond the mesorectal fascia or adopt a beyond TME approach. The second situation is that in recurrent rectal disease, where 6 to 13% of patients may have disease only in the pelvis that is amenable to surgical salvage. However, as the TME planes have been violated in this setting, one would have to adopt an extended TME approach. The surgical options depend on the quadrant of the pelvis that is involved with disease. For posterior disease, one would have to adopt various types of sacral resection. For lateral disease, the extelevator APR and extended lateral pelvic sidewall excision. And for anterior disease, defined templates for pelvic exenteration. Let me briefly describe each of these approaches and the results associated with them. For posterior disease involving the low sacrum, we have a low sacrectomy. As we see here, disease involving the coccygeus muscle and the sacrum right at the S5 vertebra. We performed a low sacrectomy at the S4, S5 disc to achieve an R0 resection. Little more advanced case in the recurrent setting, disease going into S2, 3, 4 bodies. we had to adopt a high sacrectomy, which is defined as at or above the S2, S3 disc. On close examination of the axial view, we see the S2 nerve root is involved with disease, but the S1 and the L4, L5 nerve roots are free. We were able to save both S1 and L4, L5 nerve roots and maintain function in both lower limbs. Other options for less advanced disease are the high subcortical sacrectomy, where in patients with bone invasion less than 10 millimeters and disease medial to the sacral foramina, an R0 resection can be achieved by resecting the anterior sacral cortex. The next is the partial anterior sacrectomy, where the anterior elements are resected, preserving the nerve roots and the posterior sacral elements. And finally, the high sacral segmental disconnection, resecting the hemisacrum, which is involved along with the involved nerve roots. The largest published series of en masse sacrectomy along with pelvic exenteration is from Michael Solomon's group in Australia, and they report on 100 pelvic exenterations with sacrectomy, majority done for recurrent rectal cancer. Looking briefly at the demographics, we see that nearly a third had a high sacrectomy. R0 resection was achieved in 72 patients. These are lengthy operations averaging about 10 hours and 4.5 liters. No 30-day in-hospital mortality, and hospital stay was nearly a month. If we compare high and low sacrectomy, high sacrectomy is expectedly associated with a longer operating time, more blood loss, and higher incidence of neurological deficit. But at experience centers such as this, there was no difference in R0 resection or complication rates. They present overall survival of 38% and disease-free survival of 30% at 5 years, which is quite impressive considering that this is a recurrent rectal disease in the majority of patients. Factors negatively influencing survival were involved margins, lymph node involvement, and anterior organ invasion. High sacrectomy, though associated with higher incidence of neurological deficit, did not influence the R0 resection or the survival. Lateral disease is probably the most difficult compartment to tackle because of the internal iliac vascular system, leading to the possibility of catastrophic hemorrhage, and the nerve roots along the pelvic sidewall, which can be injured or sacrificed, leading to neurological dysfunction. All this in the setting of redo surgery and radiation damaged tissues. The plane of resection of the lateral pelvic sidewall depends on the extent of disease involvement. You can see the mesorectal plane adopted for a standard TME, and the vascular plane along the vessels of the internal iliac system, a muscular plane further lateral involving the obturator internus, and the bony plane of resection removing some part of the bony pelvis. A patient of ours, a 36-year-old gentleman with disease going into the right piriformis muscle, we adopted a template of resecting the internal iliac artery and vein along with the medial aspect of the piriformis, an intraoperative picture showing the obturator nerve, the external iliac artery and vein, the ligated internal iliac artery, the distal end of the internal iliac vessels, the sacral nerve roots, the sacrospinous ligament, and the piriformis muscle, part of which has been resected along with the specimen. The largest series of lateral pelvic sidewall dissection during pelvic exenteration again goes to the credit of Michael Solomon and his group from Australia, where they report on 200 en-bloc iliac vessel excisions performed over a series of nearly 400 pelvic exenterations over 20 years. Majority of these patients were for recurrent rectal cancer. 14% had vascular reconstruction, 13% sciatic nerve resection, and 11% ischium resection. Complications were slightly higher, 82% as compared to sacrectomy, major complications being nearly 30%. The R0 resection rate was quite impressive, nearly 70%, and it is interesting to note that the R0 resection rate improved from 20% to 66% over this 20-year period by routinely adopting a more lateral anatomical plane. Anterior disease is tackled with the standard template pelvic exenterations. We have the anterior and posterior exenterations defined in the female pelvis, the anterior exenteration being mainly for carcinomas of the cervix and the bladder, the supraelevator pelvic exenteration preserving the sphincter complex, and the total pelvic exenteration. All of these can be combined with varying extents of resection of the pelvic sidewall and the bony pelvis. The most comprehensive results for pelvic exenteration have been published by the Pelvex Collaborative Group. This is data from 27 international institutions across 14 countries over a 10-year period. And it is interesting to look at the results of pelvic exenteration in the primary and the recurrent setting, both side by side. If we look at the demographics, we see that majority do get neoadjuvant therapy, and the template of resection pelvic exenteration is more or less the same in the primary and the recurrent setting in these two series. The duration of surgery is about an hour longer in the recurrent setting, expectedly due to the increased technical difficulty. However, blood transfusion is more or less similar, but the R0 resection rate, which is nearly 80% in the primary setting, falls down to 55% in the recurrent setting. Morbidity is more or less the same, with major complications being 37% in the primary setting and 32% in the recurrent setting. It is the R0 resection that offers the survival advantage both in the primary and the recurrent setting. R0 resection is associated with a 56% 3-year overall survival in the primary setting, falling down to just 8% if we do an R2 resection, and we see a similar trend of results in the recurrent setting as well. Factors predicting overall survival include the R0 resection rate both in the primary and the recurrent setting, the incidence of nodal positivity in the primary setting, and whether or not bone is resected as part of the template in the recurrent setting. Resecting bone for a recurrent rectal cancer is associated with probably a higher R0 resection rate, as shown in the series, 67% versus 56%. Looking at our own experience of extended TME at the Tata Memorial Center in Mumbai, over a 9-year period, we performed 118 extended TMEs, and we can see the various templates of resection depending on the quadrants involved. We also performed 259 pelvic exenterations during this period, mainly for primary rectal adenocarcinoma. We have in our population, patients tend to be of lower BMI. A majority of our procedures are open, but we did manage to offer minimally invasive pelvic exenteration in 25% of patients, and 12 patients had an en masse low sacrectomy. We choose fit patients for this procedure, average 1.5 liters blood loss, a hospital stay of 12 days, and a complication rate of 52%. We did have 1% mortality in this series, which is quite comparable to the pelvic data. We are able to achieve a 90% R0 resection in our series, and the pathological T4 is 46%, which is also comparable to reported data. We are looking at long-term outcomes in our data. An R0 pelvic exenteration definitely offers a survival advantage, but is life worth living following this morbid procedure? Let's look at a systematic review evaluating quality of life following pelvic exenteration. And we see that quality of life does return to pre-surgical levels about 6 to 9 months following the procedure. And if one were to compare quality of life between APR and total pelvic exenteration, although in the immediate post-operative period, the quality of life favors APR, after about 4 months, this difference is dissipated. To sum up, the surgical approach for locally advanced or recurrent rectal cancer depends on the quadrant of involvement of the pelvis. These are specialized procedures with high morbidity but low mortality at experienced centers. The survival advantage is only if we can achieve an R0 resection, and the quality of life does return to baseline and is comparable to APR. Thank you.
Thank you, Ashwin.
Thank you.
That was a great presentation. Very impressive data. One question which is actually I feel it is to Professor Leroy. is how do you identify the superior and the inferior hemorrhoidal vessels? That's from the audience. And do you ligate or clip or buzz? That's the question. I presume it is to Professor Leroy.
Yes, I'm switch on the hemorrhoidal vessels, you're saying.
Yeah, I mean, that is the question. I guess they mean whether you, while doing a transanal, probably do you take the superior rectal artery? And is that, I presume that is the question. I don't think we can get it.
But
that's precisely the question.
Yeah, no, you have to take care, but using, I would say, sealing system, sealing device now, it's easier than in the past. You have seen the dissection I did with monopolar. If there is big hemorrhoid vessels, we have to use a sealing system. It's better than clipping, because clipping, when we will manipulate, the clip can fall. So I prefer to use sealing system.
Right, sir. Right. Thank you. Thank you. So one question to Professor Smart. Do you use anything special to identify the ureters when you're doing a complicated diverticulitis surgery?
No, I haven't. And again, the European cytokiller proctology guidelines do address this. And the question has been asked, what about things like prophylactic stenting? They are not routinely recommended. I have to say, I can think of one case over the past 5 or 6 years where I have required ureteric stenting intraoperatively. But overall, it's not something that I routinely use or require. I know some people, as was beautifully illustrated before, like in the ureter to help highlight its path. But whether that categorically reduces the rate of ureteral injuries is not established at this point in time. So it's not a routine practice, not yet.
Ashwin, one question for you. The procedures that you showed and talked about are very extensive. Generally, Indian patients are not very good on GC. Do you think they tolerate this well? And what is the preoperative care and optimization that you do?
Yeah, actually, these patients are quite fitter than one would expect, because the patients that come up for surgery are the ones that only have the local recurrence. So if they have systemic disease, they are no longer surgical candidates. So as you see in our data, they are young patients with very localized disease in the pelvis, but as it is mostly recurrent or it is a T4B lesion, it has transgressed the mesorectal TME plane. So these patients are quite fit, and it is only the fit ones that we take up for these extensive resections. As you can see, the morbidity is quite significant, and we have no ASA3, very few ASA2, majority ASA1. But if we do get an RGO resection, these are definitely worth it. So we do go ahead, yes.
Thank you, Ashwin. And with this, thank you all, Professor Smart, Professor Leroy, Professor Ashwin. You have been very kind to give your valuable inputs for this session. Thank you very much for joining us, and thank you for answering the questions. I would request the coordinator to go on to the next set of next session, which is also on papers.